Hello, thank you for joining us today. I am Dr. Omar Escondrillas, the Chief Programs and Research Officer at the National Health Council. Today, we're here to talk about the connection between heart and kidney disease, and more specifically, the importance of detecting kidney damage early. We'll explore how to protect renal health and uncover hidden heart disease risks. We'll also discuss a screening test known as the urine albumin to creatinine ratio, or uACR. The uACR test checks for the presence of albumin in the urine, which can be a sign of damage to kidney tissue or blood vessels. Because damage to kidney tissue or blood vessels may also suggest more widespread damage to the cardiovascular system, a uACR screening is a highly effective way to uncover hidden cardiovascular disease risk as well as kidney damage. Here at the National Health Council, we are committed to spreading the word among healthcare providers about why uACR screening is critical for detecting cardiovascular risk early, when meaningful steps can be taken to help prevent heart attack, stroke, and other major cardiovascular health events. As always, we encourage everyone to consult with their trusted healthcare providers for medical advice and to create their own personal plan for managing their health. The National Health Council's mission is to provide a united voice for more than 200 million people living with chronic diseases and disabilities and their family caregivers. We work to expand access to affordable, equitable healthcare in partnership with our more than 200 national health organizations and businesses as members of the National Health Council. I am pleased to be joined by a panel of trusted messengers. This group of healthcare providers are uniquely qualified to raise awareness of the connection between cardiovascular and chronic kidney disease, and to offer guidance to other healthcare providers on how uACR can be used as part of an annual screening, especially for patients with type 2 diabetes and or hypertension. These experts have a deep understanding of the importance of uACR screening as an early indicator for cardiovascular disease risk. I'd like to begin by welcoming Dr. Lee Kirksey. Dr. Kirksey holds the Walter W. Buckley Endowed Vice Chair in Vascular Surgery in the Department of Vascular Surgery and is the Chief of Health Equity at the Cleveland Clinic, Seidel, and Arnold Miller Family Heart Vascular and Thoracic Institute. He's a member of the Board of Directors for the Association of Black Cardiologists. His clinical interests include the medical and surgical management of the end-stage kidney disease patient. Dr. Kirksey's research interests include clinical outcomes and the origin of cardiovascular health disparities across vulnerable communities. Welcome, Dr. Kirksey. We're also joined by Dr. Vargas. Dr. Veronica Vargas is the Director of Critical Care and Cardiovascular Services at El Camino Health in Mountain View, California. Dr. Vargas brings deep clinical expertise and operational leadership to her role and leads multidisciplinary teams to advance patient safety, quality outcomes, and evidence-based practice across critical services. In addition, Dr. Vargas is actively involved with the National Association of Hispanic Nurses. Thank you for being here, Dr. Vargas. Finally, I am pleased to introduce Dr. Katie Cardone. She's a professor and chair of the Department of Pharmacy Practice at Albany College of Pharmacy and Health Sciences in Albany, New York. For the last 2 decades, Dr. Cardone has focused her clinical and research activities on improving outpatient care for people with kidney disease. She is part of the leadership of the Advancing Kidney Health Through Optimal Medication Management Initiative and is the lead author of the Practice Standards for Pharmacists Working in Kidney Settings. She is involved in Saving Kidneys, Hearts, and Lives initiative with the American Society of Nephrology. Please join me in welcoming Dr. Cardone. Thank you all for being here today. Let's jump right into our discussion, shall we? So I would like to begin first by setting the clinical context around the cardiac kidney metabolic connection. So Dr. Kirksey, how are hypertension and diabetes interconnected as major risk factors for cardiovascular disease and kidney disease? And also, why is it important for patients to understand that connection early on?
For so long, both patients and providers have thought about cardiovascular disease and the causes as separate entities, separating out diabetes and hypertension and hypercholesterolemia. Now, we currently have a greater understanding that although the pancreas for glucose control, the kidneys for renal function, and the cardiovascular system, they're different organs, they all work as a singular system. And they impact one another to the extent that if you have cardiovascular disease, that can cause kidney disease. And if one has kidney disease, that can cause cardiovascular disease. It's very bidirectional and interconnected.
Thank you so much for that. And Dr. Vargas, I'll go now to you. Can you please explain, as Dr. Kirksey alluded about the bidirectionality and relationship between heart disease and chronic kidney disease, but particularly how does kidney and vascular damage increases cardiovascular risk?
Yes, thank you for that question. The bidirectional relationship is acknowledged as the cardiorenal syndrome or the cardiac kidney metabolic syndrome. And when we have those two conditions, it leads to a cascade of risks like fluid overload, decreased cardiac output. When the kidneys are affected, it imbalances the hormones, electrolytes. It causes inflammation and a change in the cardiovascular structure. It does lead to an increased cardiovascular risk that include any of the major adverse cardiac events, sudden cardiac death, heart failure, arrhythmias, atrial fib, stroke, and it increases our mortality and our morbidity.
Thank you for that. And I mean, despite its importance, early kidney damage is frequently under-recognized. From your perspective, Dr. Cardone, why does this gap persist?
Yeah, so chronic kidney disease is often under-recognized and underdiagnosed, and I think a lot of that has to do with the fact that it is asymptomatic in nature. A patient may not have any idea that he or she has anything wrong with the kidneys. The other thing is the risk factors for kidney disease that we talk about. We talk a lot about hypertension, we talk a lot about diabetes, but those are also asymptomatic in a lot of patients. And so for someone with hypertension who doesn't see his or her healthcare provider on a regular basis, or maybe doesn't have a primary care provider at all, may not know hypertension is a problem. Getting screening for blood pressure, getting screening for diabetes, particularly those who are overweight, is a really important aspect of identifying the earlier stages of cardio-kidney metabolic disease. And then to go along with that, of course, we can't forget testing for kidney function. So we think about the two tests, thinking about eGFR testing, and then also looking at uACR, which I know we're going to delve into a little bit more today. But having both tests is incredibly important to properly assess someone's stage of kidney disease, if it exists, but then also the risk for progression of kidney disease or a cardiovascular event.
Thank you. Dr. Vargas, why is it so important for clinicians to detect kidney damage early, primarily both for kidney health and cardiovascular health?
So it is important for clinicians to screen early, detect early, so that we can prevent any further kidney damage, so we can prevent any of those other risk events that happen to impair our cardiovascular system or our kidney system. So early detection is important.
Yes, thank you. Dr. Cardone, you have experience both professionally and also personally. Would you mind sharing how this played out in your family?
In my own family, one of our relatives had long-standing cardiovascular disease, had a heart attack, had long-standing hypertension and diabetes, and he didn't know that he had kidney disease. So when we would ask about his kidneys, the response would be, nope, nobody's ever mentioned I have anything wrong with my kidneys. Eventually, he ended up with acute kidney injury on top of having chronic kidney disease, and was told he needed to potentially start dialysis.
Thank you for sharing that personal story with us and why this discussion is so critically important, not only from your view as healthcare providers, but also that we all have loved ones that potentially may have, experienced some of these risk factors that we're speaking of today. Dr. Kirksey, I would like to ask you, what are the consequences of undiagnosed kidney disease and these underlying risk factors? Can you elaborate a little bit more for us, please?
Yes, as a vascular surgeon, I frequently see patients that have carotid stenosis, that have cardiovascular disease, peripheral artery disease, or PAD as it's known, or even end-stage kidney disease that require dialysis. For the majority of my career, I've often thought about what it would look like if we could have identified these patients earlier, slowed the progression. They may have never required any type of surgical procedure. And so the cost of not diagnosing these diseases earlier are extraordinary, both to the patient, their family.
Dr. Kirksey, can you please explain what the uACR test is and how it is different from the standard urine analysis from other kidney tests, such as the eGFR blood test?
It detects earlier disease. It's the best test that we have to detect early kidney disease, right? That early kidney disease, which is a risk factor for not only kidney damage and kidney failure, but is also a risk factor to indicate that there are cardiovascular. It's an amplifier when one has an abnormal urine albumin. It's an amplifier of overall cardiovascular disease health. To Dr. Vargas, to her point earlier, heart failure, atrial fibrillation, myocardial infarction, stroke, peripheral artery disease, all of these are increased when one has a urine albumin. And so the urine albumin is a function of injury that occurs at a microscopic level, at a capillary level, within the glomerular capillaries. And this causes leaky capillaries. This albumin in the bloodstream starts to leak into the urine. That's one mechanism that we know exists. We also know that the renal tubules, I don't want to go back to medical school or nursing school or our basic science too much, but the proximal renal tubules stop reabsorbing albumin in a normal function. And when they stop reabsorbing albumin in a normal fashion, that albumin leaks into the urine. And so these are both microscopic changes. To Dr. Cardone's point, patients would not have any outward symptoms. It's silent. They would not know about it. Their provider would not know about this unless we check in uACR. Your creatinine won't be changed at this point. Your eGFR won't be changed at this point. Very subtle and subclinical. That is the opportunity that we have here in this test, which is a simple test. It's a urine analysis. It's not a blood test. It can be done in your doctor's office. It doesn't require being done in a hospital. It can be done in a screening facility, an outpatient, a community screening facility. And most insurances cover this.
Dr. Cardone, in addition to identifying kidney damage, the uACR test can reveal early hidden cardiovascular disease risk. Can you explain how early kidney damage can reflect the broader vascular injury that could contribute to cardiovascular disease risk? And how does the CKD eGFR test heat map illustrates that hidden risk?
One of the illustrations that I find really informative and kind of profound is the KDIGO heat map that we've actually been using in nephrology for many years. What it illustrates is the relationship between eGFR and uACR and the risk for poor prognosis or progression of disease. If you look at the relationship in the heat map, it actually indicates a worse prognosis for cardiovascular outcomes, kidney outcomes, progression of kidney disease, and so that holds up across lots of different outcomes that are explored. So at the same eGFR, as a person has more protein in the urine, the risk is worse. So someone can have normal kidney function, have a normal GFR, but having significant amounts of albuminuria increases the risk for progression of disease for all these different outcomes.
What other terminology may be used to refer to the uACR test?
It'll be important for whoever is trying to use this test to explore their own health system and how they should order the test. It may be called a microalbuminuria test. It may be called an ACR, albumin to creatinine ratio. It may be called urine albuminuria. But you're really looking for the uACR, so a urinary test looking at the albumin and the creatinine ratio in the urine.
Good. Dr. Kirksey, another question for you is, how does a standard urine analysis differs from a uACR test?
That's an excellent question. How does a standard urinalysis with just a protein assessment differ from the uACR? And patients will tell me this when I talk about uACR. Well, doctor, I had a urine analysis and they said I didn't have any protein in my urine. So urine albumin is a subtype of overall protein, a subtype of total protein. Urine albumin is a much earlier change within the UA to CR. This urine albumin represents a much earlier change in the kidney function at a point when the total protein that one might see in the urine analysis will still be unchanged. It will still be normal at this point. And so once again, this uACR is a much earlier detectable change within the microvascular of the kidney and demonstrates evidence of kidney dysfunction and increased risk of cardiovascular disease. It's an amplifier of cardiovascular disease.
Dr. Vargas, I'll go back to you. Which high-risk individuals are considered the best candidates for uACR testing?
Definitely those that are obese, smokers, anyone that has high blood pressure, abnormal glucose, maybe an abnormal A1C, any of those types of patients, that, and also those that have social determinant of health complications that add to their decreased health.
So why should clinicians know about the current guidelines on uACR and early kidney damage detection as part of the patient's comprehensive risk assessment?
Yeah, that's a great question. We really need uACR to be assessed, as we've been saying, to identify those people who have that microscopic damage early on. I'm a pharmacist, there are many medications we can use to help slow progression. There's lifestyle changes that can absolutely be used to sort of arrest some of those processes in place. Things around weight loss, controlling blood pressure, controlling diabetes, and then not only doing those things that are, of course, healthy, but using specific types of medications as well can further reduce risk for progression of all of these different chronic disorders.
We also talked today about disparities, underserved populations, communities, and access to a uACR test. Dr. Vargas, in your own view, how might wider adoption of the uACR screening help reduce disparities in kidney and cardiovascular outcomes among underserved or higher-risk populations?
I believe the key is for a wider adoption is knowledge, education, training, just bringing that education or the awareness to our clinicians that are in the clinics in the outpatient setting. Perhaps using an interdisciplinary way of providing early screening to those individuals with risk factors, like bringing in the community, maybe just providing resources for individuals sooner, especially when they're identified as having risk factors, early risk factors. And making sure that we bring the awareness to the community level. Yeah. And if I may add to that, some of us that are in nursing professions or with our organizations, we go out and volunteer in the community and we provide like blood pressure checks and glucose checks, but we don't provide that uACR test, which would be easy to do. I think that would be another opportunity to do early screening.
Dr. Sloan, what advice would you give to clinicians who are less familiar with the uACR screening but want to integrate it into their own practice?
I think the first thing is figuring out how to order the test at your own institution. So finding out where it is in the order set, what is it called, and then trying it out with some patients at risk. One of the things I would say is that if you're not doing your analysis in your practice at all, logistics of that need to be worked out. Who will tell the patient to do the urine sample, who's going to provide the instructions, where will the patient put the urine sample, how is that going to be brought to the lab. So just thinking about the logistics of urinalysis is an important aspect if the practice isn't doing urinalysis already. I know, talking to some of my colleagues, clinical pharmacists are in primary care offices, I'm in a nephrology setting, some in cardiology, but not every office is doing urinalysis right now. So primary care is in some of the cases, but some of our cardiology colleagues are reporting they're not currently doing urinalysis, and they would really need to think about the logistics of how that would work in their own practice.
Great recommendations. Thank you for providing that insight that logistics is also very important, not just ordering the test, getting the test, but how are you going to process the test. So thank you. Now, to each of our panelists, in your view, what is the single most important message that you want your colleagues or other viewers to know about the role of early kidney damage detection in improving renal health outcomes as well as cardiovascular health? So I'll start with Dr. Kirksey first.
We understand that kidney health determines cardiovascular outcomes, and conversely, cardiovascular disease impacts kidney health. And if we're going to best serve the patients whom we care for, we should emphasize that. We should have those discussions with patients. We should actively seek to identify these early detectable states of kidney health before clinical disease develops.
Mm-hmm. Dr. Barres?
I would like my colleagues to know that cardiac kidney metabolic syndrome has a very high morbidity and mortality, but they can change that around by screening early and bringing that lifestyle change and that preventiveness to their patients.
Thank you. Dr. Cardone?
What I would like my colleagues to know is we need to act. We have had data about uACR for a long, long time. We've had evidence for RAS inhibition benefits. We've had evidence for SGLT2 inhibitors. We have evidence for GLP-1s. We need to use the medications. We need to use the screening tests and not just have the data. Patients are losing out if they're not getting access to those screening tools and the subsequent medications and interventions that we could do. So my message is act.
So I wanted to thank all of you again for participating in our discussion today. Chronic conditions such as heart disease, kidney disease, diabetes, and hypertension places enormous burdens on patients, healthcare providers, and the healthcare system. While we have more tools than ever to identify risk, those tools are beneficial only if they are used. Screening tests like uACR are critical because they can help slow or prevent disease progression and improve quality of life. But they can only help patients if providers know to order them. If you're a provider, we encourage you to take the knowledge you've gained today, share it with your colleagues like your colleagues have shared that with you today, and help spread the word about uACR screening and its role in the prevention of cardiovascular disease and kidney disease. If you're a patient, I hope you will consult with your trusted healthcare providers to develop a personalized plan that best supports your health and your well-being. For more information, visit the National Health Council website at the address on the screen. Thank you so much.